So I want to start by first really welcoming you to Smith School for Social Work and to thank you for taking the time to speak with us today, and to kind of introduce you to the people that are going to be watching this. I'd like to start with a really general question, which is really asking you about kind of the body of your research and how you would describe the research that you're doing now and of your research agenda.
Sure, Dr. Torres. Thank you so much for having me here. It's an honor to be here at the School of Social Work at Smith College, or the School for Social Work, actually, at Smith College. So the work that I've been doing over the past almost 10 years now focuses on understanding the factors that contribute to health and mental health disparities, particularly among the Latino population. And then trying to use that information, that knowledge that we are developing to help us develop and implement interventions to address those disparities. So I see my work as figuring out what those disparities or inequities in health and healthcare are among the Latino population, and then using that to develop interventions. And my hope is that this body of work can actually help us develop interventions that practitioners can use, that can be implemented in community mental health centers, that could be implemented in primary care services, so that it actually addresses the inequities that are impacting the Latino community. And over the past 5 or 7 years now, I've been working particularly with Latinos with serious mental illness, so those that have schizophrenia, bipolar disorders, and particularly in the public mental health system where most of the individuals are served, and trying to figure out how to improve disparities around physical health issues, so cardiovascular disease, diabetes, hypertension. What really I'm passionate about is to figure out how do we then partner with practitioners and partner with communities to create interventions that people can use, that the social workers at these clinics can use, that that benefit and are relevant to the population that we're serving. So the questions focus is not only what this intervention should be, it's also how they should be, what do they work, and how do they work in the community, so that then we can implement it. And I hope for the future that my work helps address some of those inequities, so we're moving towards eliminating them. And also a passion for training social work students, training doctoral students, training providers. The work that I've been doing is really engaged with all of those individuals. So I'm hoping that it leads to a training component, that we're not only developing science, but also training other people on how to do this.
That's great. That's wonderful. And so I did have a chance to look at your CV, and one of the things that I really admire about your work is that you have worked in the field as a practitioner, and so I feel like being a practitioner researcher, kind of holding both, is really helpful in understanding the needs of the individuals and communities. So I'm curious how you see it helping you in your work, or how you use that kind of practitioner knowledge to get buy-in, or et cetera.
Oh, I think it's been critical, because the work that we're doing at the end of the day needs to be done by a practitioner in the community. So I started this working in Puerto Rico, actually in Bayamón, which is a small town next to San Juan, working with people with developmental disabilities. Who were actually was an institution that serves children, adolescents, adults, and elderly. And my job there was to actually develop programs for their elderly population. So really trying to figure out what type of programming will we need for improving the lives of these individuals who were aging in this institution. And I was right out of college. I didn't have my social work degree. I was sort of trying to work out with a social worker actually that had their degree what programs will be. So I really carry those experiences close to my heart, that if the institutions have the services that the people need that are relevant for them, they can improve life. But if they don't, they can actually create negative impacts in people's lives. So having worked in different areas, when I was a student in my master program, I worked, one of my interests was an inpatient psychiatric unit, and really learning how do someone recover from a psychotic episode, recover from an episode of mania, and connect them back to the community. And that was a really interesting experience. I also worked at crisis hotline service, so people who are calling for crises, particularly around suicide, and how to provide them crisis interventions in those situations. So that's another experience of figuring out how to deliver services through a telephone on such a stressful situation and in a crisis mode. And then over the years, I've kept doing projects that we're partnering with practitioners. Practitioners are part of our team. They're the center of what we do, and we want to partner and engage with them. And that knowledge that comes from their practice actually informs our science. So one of the projects that, actually one that I'm presenting here today, comes from a partnership, a collaborative intervention planning approach, where we're partnering researchers with practitioners from different disciplines to figure out how do you adapt and integrate a new intervention into an agency to address a particular need around physical health issues. So practitioners bring a wealth of wisdom on what engages their clients, what are the situations, what are the barriers that we're going to face in the community, and we bring sort of the methodology to study that, the research questions, and then how to capture that reality. So engaging with practitioners has always been an important part, and I think it's where research and practice really come together. I think that to me has been very important to address those two aspects of it.
What I've noticed looking at your work and hearing about your research is, really kind of the applied nature. That this is, research in the real world with all of the challenges. Yeah. And so it's really great to hear how you're working with providers and really thinking about the experience of the consumer that's coming in, sure, and the provider and this larger system of care.
Sure.
So I want to back up just a little bit. And so you mentioned, talking about disparities and inequalities in service for the population that you work with. Can you say a little bit about the kind of the disparities that specifically, what do you mean when you say disparity?
So we look at disparities as, so for example, in the work that we've been doing, we were looking at disparities in health among people with serious mental illness. And what that means is that people with serious mental illness compared to people that don't have these mental disorders tend to die at an earlier age for multiple reasons. And they die, some estimates as high as 32 years, 20 to 25 years, up to 32 years. And they die for natural causes, cardiovascular disease, diabetes, hypertension, and it's a disproportionate number of them have these disorders and are not benefiting in the same manner as the general population around diabetes, cardiovascular care, and things like that. So the inequities is around the disproportionate number of people who are actually being impacted by these disorders. And when everything is equal, if we put same socioeconomic status, we control for all those issues, we still see these inequities. In the Latino community, we have those inequities. Latinos are more likely to suffer from obesity, from diabetes, and then you put on top of that their psychiatric disorder, they are at higher risk for that, those type of things. So those are inequities in health, that you are at higher risk compared to someone else to have this disorder. And then there's these inequities in healthcare. So once need is taken out of the equation, what happens when you go to your doctor? What happens when you go to a psychiatrist? How that person treats you, the type of services that they're providing, and they're less likely to be provided high quality care or guideline concordant care. So their outcomes are worse. So we're trying to address those inequities, so inequities in health as well as inequities in healthcare delivery.
What can systems of care that these individuals are navigating, so behavioral health care and physical health care, what do you see as recommendations for systems of care to address the disparities that you're observing?
So that's a great question. I think one aspect that we've been working on is how to integrate services. So if someone comes in to the mental health system, for example, in our population, people with serious mental illness, Latino serious mental illness tend to go to their outpatient mental health services to receive their psychiatric medication, their case management, and then integrating within that system primary care, so that they're connected to a primary care doctor, they're receiving the care that they need in terms of any physical health issues. So for example, people might have diabetes, that they're being connected to a doctor that can help them with their diabetes or with their hypertension. So the integration of services becomes really important because right now our service system is fragmented. You have to navigate from one to the other, and actually navigation is sort of a dual process. Person has to go from one system to the other, and many people get lost in the system. It's up to the patient and their families to communicate between multiple doctors, multiple treatments, multiple medications, and all the complexity that goes into that. So integrating care, helping someone navigate that system and actually receive care where they go. So put services out to where they feel more comfortable, where they feel more engaged with. So those are important aspects. The other piece is to provide services, actually think about outside of the system, where people are actually spending most of their time. We go to the doctor, for example, for chronic illness care, you might get a doctor visit every 3 months. You might get a visit that lasts 15 minutes, and then the rest of the time you're out there in the world living with this condition. So how can we provide you services when you're out there in the world, at your home, for example, or where you live, at your apartment, or in community centers where you are involved? So one of the interventions have been to bring interventions out into the community, a healthy lifestyle interventions around diet and exercise, which are so important for chronic illness and obesity. So how to help someone have the knowledge and the tools to engage in a healthy lifestyle. So bringing those interventions out to the community are also very important. And I think our health system is beginning to realize and beginning to develop services that are innovative in that sense, that we have a better reach into people's lives. Technology has made that a little bit easier. If anyone has a smartphone, your smartphone now can count your calories, can count your steps, can give you exercise tips. So all of those tools can help us improve the services. The challenge is how we're going to pay for that. So now in some states, there is money to integrate services and pay for those, which is very important. And social workers, we're uniquely equipped and trained to do that. We are the person who's helping that person navigate from one place to the other. We are the persons who have more contact with that patient or that client in a sense, and their support system, to help them go from one system to the other and to engage them around all these physical health issues and mental health issues as well. So that service integration, I think, becomes really important for addressing these inequities. And we know there's great studies indicating that if you deliver with high quality of care, with good fidelity, you can actually reduce disparities in this area. So that's one aspect that I think our work is trying to develop evidence and approaches on how to do that for these populations.
Thank you.
Yeah.
Thank you. I know that one of your studies focuses on the use of peers to help individuals, and the individuals in this study are in supportive housing specifically, and helping them make healthier lifestyle choices. So would you think, is that an example of the integration that you're thinking about, or how was it in terms of using peers in the study or working with other providers? What was your experience of that?
Oh yeah, so that project actually is an interesting approach of how we were approached almost 5-6 years ago by supportive housing agencies to figure out how to improve the health of the clients that were being housed in the supportive housing agencies. Supportive housing agencies provide housing to people who have been homeless. This agency is particularly focused on people with serious mental illness with a long-standing history of homelessness, or what they call chronic homelessness. So they were providing housing, they were providing people connection to mental health services, and they began to identify that their clients also have serious physical health issues, obesity, some had cancer or being identified with cancer, diabetes, hypertension. So this agency came to us as part of our research project to figure out what can we do. And instead of looking at the literature and saying this is the solution for your problems, we took a step back and said, why don't we talk to the clients? Let's figure what these clients actually want, what they think of their health, what they think are their needs, and what will benefit from them. So we did a Photovoice project, where we basically is a participatory action research project. We gave people cameras, and people go out and document their everyday lives. And then they come together and they talk to us about their lives and their experiences, using the photos as an opportunity to open the door, to provide us the stories behind those photographs. And it was a great experience. We did it in 2 supportive housing agencies. And we learned several things that has informed this project that you have mentioned. One, people wanted peer-delivered services. So bring people who have the same lived experiences that we've had, that have walked in our shoes to talk to us about physical health issues. So former people who have a history of homelessness, a history of serious mental illness. And they feel those person has walked in their shoes, have the lived experiences that they need. They're more credible, more trustworthy, and could speak their language. So they wanted that. They wanted information and skills on how to eat better and navigate their food environments. So figure out how to shop when you have very limited resources, how to navigate your environment, but this is in New York City, your neighborhoods, how do you eat healthy with a bodega on each corner, or fast food if they don't cook by themselves. They wanted help around physical health activity. Some of them mention how physical health actually helped their mental health. So how do they safely exercise or engage in physical activity? What would be safe physical activity for them? So all of that gave us information on how to develop healthy lifestyle intervention, supportive housing. And it helped us figure, okay, if this is what people want and this is relevant for them, what evidence-based practices are out there that meet these criteria? And we were able to find a healthy lifestyle intervention that had been delivered by community health workers, which are different than peer specialists. Peer specialists have had a lived experiences of recovering from mental illness. They have received services. They're trained to work with people, versus a community health worker might be someone just from the community who might not have the actual lived experiences, but they might know the community. So we found a healthy lifestyle intervention that met all those criteria. It was evidence-based, has been tested in multiple communities around the country. It's called the Group Lifestyle Balance Program, which is based out of the Diabetes Prevention Program. It's shown very good results on helping people reduce their weight and actually prevent diabetes. And then what we did, we modified it so that peer specialists can deliver them. And that's what we're doing right now. That's the research question. Can peer specialists deliver this intervention with fidelity and have the same outcomes as in our population? And we're in the middle of that right now. And peer specialists bring something unique, bring that credibility, that aspect of how to communicate with someone at their level. And when I mean at the level, sort of at their reality of where they're at, and how to make these concepts of how do you eat healthier, how do you exercise, how do you address economic issues, and provide examples from their own life. And it's not easy. Even as a professional, we try to do this work, and it's really difficult. I mean, changing your weight or changing your way that you eat and you exercise is the most difficult behavior to try. But we needed to try. We wanted to see if it works, and we're right now using rigorous methodologies to really figure out whether that's working. So peers have a unique, I think, a unique place in the service system. And the other piece is economics. Right now, with the Affordable Care Act, there's an expansion of funding opportunities for peer specialists across the service system. So they could, some places, in some states, if they get certified, some certification that happen within the state, they can also get Medicaid reimbursement. So there are growing workforce that is there, and it's being used in the mental health system for many things. And this is one other service that they can actually provide. And there's evidence that they can help around physical health issues. Other groups who have done this type of work. So it's really interesting. The challenge is, how do you identify this individual? How do you train them? How do you supervise them? And how do you integrate them into the agency? Because it is a different workforce. So what we've been finding is that we need to train not only the peer specialists, we need to train the agency, we need to train the supervisors, and work together and work through the issues that come up around workforce development, around supervision, around trust between the different staff members, and that they become part of the agency. And I think we've been doing a good job on that, but we're learning a lot on that process. And so we're very excited. Peer specialists have been a really interesting workforce to do, and we're learning a lot. We're learning a lot from them about how to do this work, and I think they are strengthening the intervention at an ecological level that we wouldn't have done if we were just delivering by professional or with students, highly trained clinicians. They bring in a whole different level of wisdom that are unique for the population that we're working with.
That's wonderful. I'm a huge fan of the use of peers and the recovery movement in general, and thinking about the use of peers in different settings, and really recognizing that there are a lot of people in recovery at all levels. So, it might be a social worker that is themselves in recovery, but to use peers to get that kind of credibility, that real understanding at a granular level of what this experience of navigating a doctor's office or the supermarket, as you mentioned, just the world, the real world, not just the doctor's office. It's great. It's wonderful. And I'm kind of curious, you've talked about kind of the benefits from a physical healthcare kind of perspective, but given you're working with people with a severe and persistent mental illness, what kind of benefits have you noticed for their mental health and well-being?
That's a great question. I think there is a synergy between one or the other. People say that your mental health is critical for your health, your physical health is critical for your mental health. So in some studies that we're finding, people have reported that, for example, engaging in exercise improves their mood, improve their social ability, their social world. They become more connected to their social world. It's what in one study that we have been able to connect people to primary care. One of the things that we noticed that people also began to get more engaged in their own mental health care, because the skills of how to connect to primary care, how to talk to a doctor, they could also translate that to the discussion they had with their psychiatrist. By focusing on the physical health, we're also beginning to identify how people manage the side effects of antipsychotic medication. Many of our clients and participants are taking antipsychotic medications that have serious side effects if they're not managed. So by helping them connect with their physical care and their health care, they begin to also notice, okay, how can I have a conversation with my psychiatrist about the gain weight that I'm having with my antidepressant or antipsychotic medication? How could I improve my diet around those issues? What do I need to be aware of? So it has a synergistic effect between one and the other. That's really important. And when we've talked to people using qualitative methodology, people say, I'm one person, I'm one body, one mind, and they have to be treated all. And it was interesting. We have one. We never published it, but it's one person who talked about, or a group of people who were talking about their physical health, and they were getting very frustrated. And they will say that, I'm sick from de pie a cabeza, from head to toe. Everything is wrong, and they were not making a determination between their head and their body. It was all a problem that they were having, and they wanted someone who could help them with all of it, with their mental health issues, as well as with issues of hypertension and diabetes and all the other things that they were having, so that they were not then a person who say to them, I'm not sick from head to toe, I'm actually getting better. So I think that's a really important piece, that one helps the other. And we need to do a better job in mental health around not only the mental health issues, which are very critical, and helping someone recover from their mental illness, which is possible with the right types of treatment and support, but that we also pay attention to their physical health. So some people are now indicating that you receive, actually the guidelines are now, that if you receive an antipsychotic medication, you also need to receive physical health issues, screening for diabetes, for your weight, for your blood pressures, for your cholesterol levels. But we need to move before just monitoring. We need to move to actually intervening, providing people the skills that they need to manage all those things at the same time. And the earlier we start, the better. We don't need to wait until someone is obese to help them with their obesity. If we know someone is receiving antipsychotic medication, they're going to gain weight, help them manage that. And it's really important for mental health. I mean, when we looked at the literature on what predicts, in many ways, people not taking their medication, a lot of it has to do with how the medication makes them feel, their physical health issues that come up with that. So it helps if we integrate both of those. That's sort of a theme of my work, as you can see.
Yeah, definitely. And I can definitely see how a peer could really help bring voice to some of those concerns, just to kind of encourage the conversation with your psychiatrist or your physician, or et cetera. I'm kind of, as you talk about, the whole person from head to toe, before we started taping, we were having a conversation about intersectional identities and how, the individual is not just a body. It's a body in the world that's perceived in different ways based on their social identity or location. And I know you get that because you're focusing on disparities and thinking about the Hispanic population in particular, but it's much more complicated than that.
Yeah.
So I'm wondering how you think about intersectional identities and how is that navigated within the studies you do or the work that you do with communities.
Yeah, that's a great question. I think intersectionality captures a lot of the work that we're doing. For example, the intersectionality of living with a serious mental illness and being a racial ethnic minority Latino, or and within the Latino, the heterogeneity of Latinos, a Mexican, Puerto Rican, and Dominican. So that intersection is sort of where we're at. That's where we place our work, and then figure out how to provide services in that complexity. So that we're looking at your mental health issues. We're looking at your identity of who you are, your gender. And then how to provide better services. So in some of the interventions is how do we then, first of all, acknowledge that and assess and understand that complexity from the client's perspective. So one of the projects that we have, we included an interview component called the cultural formulation, which is an instrument, the cultural formulation interview, which is an instrument that is part of the DSM-5, believe it or not, which great work, and it has a rich history of combining psychiatry and anthropology and cross-cultural components. And what this interview provides is an opportunity for the provider to ask questions that are client-centered, like, what do you think causes your physical health issues or your mental health issues? What do you fear most about the services that you receive? What do you hope about the treatment that you're going to get? What have you done in the past? What have you done in the present? How does your family view this issue? And it provides an opportunity to actually capture that complexity. And people, when you ask those questions, they talk about this intersection. What's most important for them, what matters most to them, becomes really apparent. And it's a way for the clinician to gain access to that reality, and then to use that information in collaboration or in partnership with the client to develop a treatment plan that fits the reality or the preferences and the need of that client. Another thing that we found is just that by the mere act of asking, you are providing that opportunity for people to tell their story, to show respect, to show basically, I care about what you have to say and how you have to say it. And it opens a conversation that we rarely get in this type of interactions. Think about it, in primary care, you get 15 minutes with your primary care doctor. There's no way you can do that type of thing. So as social worker, we train social workers to use the cultural formulation adapted for health issues, which is basically just asking for health component, because that was the input of our intervention, and it opened those doors. So that's one aspect. And then helping social workers and the clinician integrate that into the care that they need. So for example, if someone says, when we ask them that it's important for them to have their family members present, or that a family member actually is impacting how they eat, impacting how they exercise, then you have that information that you can develop a treatment plan that is centered around those issues. Or diet. That is such a cultural component. Our culture is reflected by the food we eat. So how do we then provide dietary recommendations or help them connect to dietary recommendation with the food they eat? And that's a really important component. You're going to provide someone dietary recommendations, and they eat their rice and beans, and they eat their plátanos. We can work around those issues. We can actually help them eat healthier with the traditional food and value their traditional food, versus saying don't eat those things and eat something completely different that you're never going to buy, you've never eaten, and that's never going to happen. Right. So I think that intersection helps us understand. So it's a real important aspect and theoretical perspective, but then the challenge is, how do you then take that to practice? How do you use that information to inform the practice for that individual? And we've liked this tool because it's very client-centered. It's called the cultural CFI, cultural formulation interview. But in the actual interview, you're actually looking at the individual, at the client and their social world. And that's sort of where culture lies and how to access that information and use it for them. And then another place where it has it is the interactions. Culture happens in the interaction between two individuals and their social world. So how do you then access, what are the forms, the norms of interacting with someone that is culturally appropriate, and how do you pay attention to that and be able to integrate that into service? Really, I mean, the interactions we have with people, that's at the heart of what we do. Right. So how do you connect with that individual and have a safe space when that happens and that doesn't happen? For example, when I practice in LA, in Los Angeles, in East LA, in one of my work, I'm Puerto Rican. So the Spanish that I speak is very different than the Spanish that someone from Mexican descent who's lived in LA speaks. Right. So even when we speak the same language, we have major differences. And I remember being a depression care manager, a depression specialist, helping someone with depression, and having difficulties communicating with someone who spoke my same language, but we came from different cultures. But instead of using that as a barrier, using that as an opportunity for them to say, you know what, I am not understanding you of what you're saying. You're not understanding me because of my Puerto Ricanness and your Mexicanness. Let's find a common ground. And using that opportunity, actually providing the power back to the client, saying, tell me, explain to me, help me understand what you're saying. And simple things like ahora and ahorita, which means now and then, are completely different from Puerto Rican Spanish and Mexican Spanish. Ahorita, it's completely different. So having those conversations and using that opportunity to find common ground. So even when someone might look the same or might speak the same language, there's differences there, and how to use those differences for the benefit of the client, for the benefit of their treatment, and for an engagement opportunity. And imagine the confusion. I'm telling you to do something now, and the word that I'm using for now means later to you, right. And the frustration that comes out. But using that as a great opportunity to figure out, okay, we're not understanding right. each other. Let's figure out what we can do, right. And things like that. So I think that to us has been really important. The language that we use, the expressions that we use, and opportunities to learn, to be curious about the social world that someone else is coming from. That to me, that's the art of all of this.
You remind me, one of the public lecture series speakers earlier this summer was Dr. John Jackson from Penn. And in his talk, he said, to think about what is culture, how do you define culture? He said, you might want to think what isn't culture. Yeah. Because it's everything. Yeah. It's everywhere. It's all around the choices we make, where we live, what we eat, how we communicate, what we say, how we say it, everything. So it just kind of resonated, what you were saying about that. Okay, so I'm going to just go back to my notes here. So I have 2 questions left in the time that we have. And I think you've addressed this, but I want to push just a little bit more. Sure. And so the question is, from a social justice stance, what do you think hospitals can be doing to better support individuals with a diagnosis like schizophrenia or bipolar? Like specifically, so I know you talked about integration and peers, but is there anything else that social workers need to be aware of that hospitals can be doing differently?
Sure. So I think that's a great question, because the treatment for serious mental illness go beyond biomedical treatments. I mean, the medications help. The medications are a necessary aspect of that treatment, but there's also psychosocial interventions. The person, for example, hospitals, the person comes to the hospital because they have a psychotic episode, or they have a suicidal attempt, or something seriously that is a danger to self or others. And most hospitals provide, of course, safety first for the individual and others, and psychiatric medications. But we can do better. We can do more better. How to connect that person back to the community. How to help them around issues that really matter for the individual around, for example, education, supportive employment, reconnection with social services. So, for example, one area that I've been working on, which is a new area for me, has been this whole aspect of early interventions for psychosis. So someone has their first episode of psychosis, what type of services do they need so that they can recover from their psychosis and actually connect back to their normal lives, so that there's not a disconnect between their education, their employment, their development. So early intervention services, it's a package of services around psychiatric medications, employment, family psychoeducation, supportive education, and social functioning. So it's really helping that individual, the whole package, that we go from medication to psychosocial things and psychosocial interventions. So having that aspect of it, so we look at the whole individual and provide them the services that they really need to reconnect back. The other thing, hospitals are part of communities, and they need to reach out to provide better access and better quality of care to everyone in that community. So being able to connect someone back into a system of care in that community that goes beyond just primary care clinics, but all the other social support systems that exist there, churches, temples, community centers, schools, and be part of that. And I think that helps address issues of access, address issues of trust that happen, and then engage them in programming for that community. Being on places like Colombia, which is a huge medical center, how engaging the community around Columbia University is really important. We've done, for some projects, we do a very good job. For others, we don't. But that's our community, and that's who we're serving. So we need to be very aware of the needs of our community and be able to develop services and support services that help strengthen those communities and make sure that that health is part of that of community engagement and community development. I think that's really important. Bringing services out into the community is also important. So not waiting for people to come to our doors. So hospital will be out there, helping with prevention, helping with family health, child development. All of those things I think are spaces for hospital and things like that. And in people with serious mental illness, it needs to go beyond their mental health. They need physical health issues. They need employment services, educational services, because that's what recovery is all about. To have a recovery point of mind, I think that will be very important. I think some systems are moving in that direction. I have hope that that's where we're going. But it takes a new way, a new paradigm of delivering care that we need to learn and learn from others that have been doing it, not only in the United States, but throughout the world, who have been looking at how recovery actually gets implemented, or recovery-oriented services get implemented.
Thank you. Yeah. Thank you. That's very helpful. So, so my last question is, I think it'd be interesting to hear what you would say to the next president in terms of recommendations for improving the healthcare system, specifically for people with a severe and persistent mental illness. So,
first of all, I will say to her that the most important thing that we can do is continue to expand access to care, like what has been going on. But that access is not sufficient. We need to work towards quality of care, so that not only are we opening the doors for more services in our healthcare system, but also improving the quality of services and addressing the inequities that happen among communities. So more people are going to access our services and make sure that the system of cares are ready to take on a more diverse population, people who usually did not have these services. The other thing that I would say to her is to look at prevention. Mm-hmm. Prevention is so important. I mean, if we look at the health of a population and the needs of a population, healthcare is one component of what improves health. We also need preventive efforts to have people to safer environments, to exercise, to engage with the community, affordable fresh fruits and vegetables and healthy foods, more social connections with their environment, with their work. So areas of finding prevention. In serious mental illness, particularly investing in early intervention services, so that we identify people when they really are at need in their first episodes and provide them the right type of services that we can reconnect back into the community without disrupting their lives, disrupting their functioning, and creating services that are not helpful or having that person fall into sort of a chronic mental illness, which sometimes our systems of care do that for people. So investing in early intervention services. And that's a big challenge because that takes a new paradigm of providing services that are within the mental health system but reaching beyond the mental health system, educating people about what are the signs and symptoms of a psychotic episode. And to do so among a diverse population like what we have in the United States, that we are providing information that is culturally appropriate, language appropriate as well, or linguistically appropriate, culturally competent, and addresses the need and how to connect to care faster, so that people don't spend years suffering in silence, or families actually suffering in silence before services. So that's really important. The other piece that I haven't done much work on, but I think it's critical, given how our systems are broken, is provide better mental health care in the community, so people don't end up in prison or in jails. In some places in this country, the bigger deliveries of care are prisons or jails, and that's not the right place to provide any type of service to someone who are suffering from schizophrenia, is recovering from bipolar. So preventing people from going to prisons or jail and getting the right treatment. It's also very costly to do so, to have someone in prison or in jail receiving mental health services. So that's another place where in our communities needed, that we don't use the criminal justice system to provide mental health services. We actually use our mental health service system to provide that service, and to provide it with care, compassion, and with care, and to work with the criminal justice system so that we can transition people and integrate those services better. So those are the major things that I would tell our next woman president, what could be done for the services. And then continue to innovate and continue to invest in disparities work. And not only on disparity work about identifying the disparity, but actually investing dollars in how to address and eliminate the disparities, so that we're moving from research to practice, that we are investing in how to take the interventions that we know work and they show promise, and how to get them into the community so that people can benefit from it. We invest an enormous amount of money in this country on research and development. We need to start moving toward implementation, and figuring a better way of connecting both of those worlds. Because if we create the best treatments, the best pills, the best intervention, but nobody uses them, then what's the point? We need to make sure that we are addressing that gap. And I think we have the infrastructures to do that. There's a whole new field of implementation science, which we've been working on. I personally have been working on and been trained in that area. And I can see the promise, but we need more investment in interventions, in funding around those areas. Because at the end of the day, I think that's where all these projects go to, is how to improve and address the inequities that we have. And to me, as you can see, health is really important. So it's really figuring out how to improve the quality of life of individuals, and health is an important component of their quality of life.
Right. Excellent. Well, I think that's a perfect place to end our interview. And I really want to thank you for your time and for really giving us a window into your research and your passion around it. It's really wonderful to hear.
Oh, thank you for your time today. Thanks.